presentations, and I hopefully can enlighten you in some of the aspects of this, which, to be honest, I didn't really understand a lot of it when I was assigned by John, but certainly learned a lot and have a background in health policy and reimbursement. So reducing imaging denials to me really means improving prior authorization approval. So what really is prior authorization? So prior authorization was a health insurance company payer requirement which was designed to regulate the utilization of expensive medical care. It really originated in the 60s as part of utilization reviews. Utilization reviews are used to verify hospital admissions as part of Medicare and Medicaid legislation. This process places a hold on clinical orders so the insurance companies and the payer representatives can review them to determine if a service or product will be covered. The intention was to contain healthcare costs by avoiding expensive or unnecessary medications, but success in achieving these goals has been questioned. There was a study recently that found that prior authorization related delays in dispensing anti-epileptic drugs delayed treatment of 49% of children, with 7% missing at least one dose, and 4% had increase in seizure activity. There was an AMA survey in 2022 which showed that 94% of physicians felt that prior auth process delays access to necessary care for patients, and 86% of physicians' prior authorization requirements result in increased use of healthcare resources, leading to waste, red tape, delays, instead of the cost savings that insurance claims the process helps to create. So prior authorization does place a significant administrative and financial burden on medical practice. Whether you're independent or employed, it's still a stress on your practice, your bottom line. A paper actually out of our group showed that our urology practice, it was estimated that $15 were spent on each prior authorization. Nearly 15% of all claims submitted to private payers for reimbursement are initially denied, including many that are pre-approved to move forward through the prior authorization process. I can tell you that when I was doing coding reimbursement with the AUA, we made a couple of field trips, one to Cigna and one to United Health, and they flat out told us that that's their algorithm. That's how they work. They deny 15% and see what sticks. In 2021, there were 2 million prior authorization denials in Medicare Advantage. Only 11% were appealed. Of that 11%, 82% were approved. Over half of denials by private payers ultimately overturned, and the claims paid, but only after medical, costly rounds of provider appeals. Across all specialties, the average cost incurred by providers fighting denials is over $43, meaning providers spend $19.7 billion a year just to educate these denials with payers. And there's no difference in the administrative time spent on prior authorization between private or public payers or other type, whether it's imaging or medications. And it's already been alluded to. Christian, in his first talk, said, if we can get it approved, right? That's the big issue. And we obviously have shown that this may lead to delays in patient care. And if you're setting up an imaging center, as Dave talked about, revenue collection is important, or your center's not going to survive. So what are some tips for reducing denials and delays? So I'm going to go through these 5 points in more detail. We're going to go over understanding insurance requirements. We're going to go over understanding how to ensure complete and accurate documentation, that there are ways you can automate prior authorization where possible, that follow-up is important, and appeal is also important. So first of all, understanding insurance requirements early on. And this really gets to all aspects of reimbursement in practice. A common reason for prior auth denials is simply misunderstanding each insurer's specific requirements. Every company is not the same. They don't have to have the same set of rules. Remember, they're a private entity. Each insurer has its own set of rules and criteria for approving certain treatments, medications, procedures. Revenue cycle management workers in your practice, in your hospital, need to ensure that they're familiar with the guidelines of each insurer and, importantly, keep up with changes in government coverage policies, which involves regular review of payer-specific policies, maintain up-to-date documentation. You need to ensure complete and accurate documentation. Incomplete or inaccurate documentation is a primary cause of prior auth delays. So your notes need to be clear, your requests need to be concise and consistent with CPT coding language. You need to demonstrate medical necessity indication for the examination that you're asking for. Before you submit any prior auth request, you need to verify that all the required information is present. You need accurate patient details. What's the treatment plan? What's the supporting documentation that demonstrates that the study or that medication is needed, and you need to supply test results. Your patient notes need to be accurate, detailed, because we know that any missing or incorrect information will lead to a denial, forcing you to just resubmit the request, appeal the request, and so it sounds silly, but checklists, checklist manifesto, many of you probably read the book, that will obviously speed the process for you. Now, there are ways to automate this. We all know that manual processes are prone to human error, slow turnaround time. Automation of repetitive tasks, such as checking insurance coverage, submitting requests, these can speed the process up. And as I learned in preparing this talk, there are some automation tools that can help your staff to track authorization status, requests in real time, et cetera. There's a company, which I found out about, called Thoughtful AI, which has a process called Agent Paula, which is AI, which is designed to automate and manage prior auth requests. It apparently submits your necessary documentation, follows up with payers, automatically appeals denials, reduces administrative workload, accelerates approval time, and improves patient access to care. Importantly, you need to follow up on your request proactively. You need to check with the insurance companies, see what the status is, see if they need additional information, if the request is stuck in some backlog, and you need to monitor each request's progress, addressing issues immediately. Your revenue cycle management workers can reduce the time to approval and prevent unnecessary delays by just being proactive. As we all know, there's been the Great Resignation. People don't have the workers. Patients and practices need to be proactive on following up on these things. And appeals need to be, you need to appeal your denials immediately. Review the denial, get the documentation that's needed, resubmit, and as I've shown, if you appeal it, it'll probably get covered. So while we talked about sort of bread and butter, how do we address it, what about long-term solutions? Like, what can we do about this as physicians? Because we want to take care of our patients. So advocacy is very important. So we as physicians, we can reach out to our local representatives in Congress. We can demonstrate to them how prior authorization impacts on patients, on our practice and the patients. And these patients live in their district. They're who they're supposed to be serving, and that's one way to advocate. Patients can also advocate. Patients experiencing delays can reach out to the representative. They can explain the difficulties that they're having. They can also talk to their HR department at work, because the HR department sets up the contracts with the payers, and if the insurance providers that their company is having them get their insurance with is causing all these headaches, then maybe consideration should be given to a different carrier. A couple other ideas that came up in my reading. Perhaps new CPT codes should be designed for the work that's taking place with this. There are nurse navigation codes out there. Part of the nurse navigator is to do this. Well, the nurse navigators get paid for the work they do if they use the proper codes. And then lastly, I know a lot of people find the AMA to be controversial, but supporting the AMA may be beneficial. There are some AMA policies that are present, a little bit wordy, but currently in the AMA policy, it says that the AMA supports payment to physicians by contractors, third-party payers, for physician time and effort in providing case management, supervisory services, including but limited to coordination of care, that's nurse navigation, and staff time. The policy insurers should pay physicians fair compensation for the work associated with prior auth, including pre-certification, et cetera. They urge insurers to adhere to the AMA's Health Insurer Code of Conduct principles, requiring that the insurance agencies kind of play ball. And interestingly, at the recent AMA meeting, the AACU, Dr. Reha from Virginia, put up a proposal to get play a little more hardball with insurers, and they felt that the AMA should actually initiate prior auth legislation aimed at Medicare Advantage plans, state Medicaid programs, as well as commercial payers via legislation to allow for fair reimbursement for the physician's time and that of their office staff when dealing with prior auth. We all know that physicians have not seen an increase in their pay in 20 years, but our overhead is going up. So these are things that are potential. I talked to Reha the other day, and it's sort of lost in the AMA, what they really want to do sequence, but it's there. So in summary, reducing denials, really reducing imaging denials relies on careful navigation of the prior auth process. You need to understand the insurance requirements early on, ensure complete and accurate documentation, automate processes where possible, follow up proactively, appeal denials immediately, and potentially there may be some long-term solutions via advocacy, nurse navigation, maybe a new CPT code, maybe something the AMA can do for us. Thank you.